wife looks very righteous, the husband is very sad, because it's been discovered that after she has gone through the whole gamut of investigations which she need not have gone through, the man finally had a semen test done, only to discover that he was azoospermic. So actually a slide which I show in most of my talks is the first step in the evaluation of an infertile couple is the semen analysis. Unfortunately, even today, I find that every scope that the gynecologist had has been put into the wife before the man does the semen test, only to then discover that he is azoospermic, and that's not fair. So in the past, the management of azoospermia is very simple. Man came with a sample, you sent him to your surgeon, who between his major hernias, hydrocele, etc., did a quick biopsy. If the biopsy was normal, he attempted a VA which failed, and then you did donor insemination. If the biopsy was abnormal, you did donor insemination. So the end point was easy. Now, about half the men with azoospermia have the opportunity to father their own genetic child, which means that the whole thought process, the investigation, the management needs to be far more complex. So that's what we're going to summarize in the next 16 to 17 minutes. Before we go into the actual algorithm, a few practical pointers which you need to remember. And the first message, a strange message, is that sometimes a semen report is not a semen report. There are some men, almost 10% of men have difficulty ejaculating by masturbation, and there are some of these men who, when asked to give a semen sample, actually don't give semen. They struggle and huff and puff and void a few ml of urine, or they massage the penis and collect the urethral secretions, and you will get a report 0.5 ml azoospermia fructose negative, and that wasn't really semen to start with. And we've had many of these men who we suspect from their history have difficulty ejaculating, have not given a proper semen sample, and we treat them on the vibrator, and suddenly azoospermia becomes 60 million or 90 million. So one take-home message, a warning: if a man says, "Doc, I find it very difficult to give a semen sample, and this one semen sample is all I'm willing to give, and it is low volume or yellowish in color and fructose negative," it might not be semen at all. The second message to bear in mind is that one semen report of azoospermia does not mean azoospermia. Time and again, I see patients, they've gone to a urologist or a general surgeon, first report azoospermia, next step testicular biopsy, and sure enough, 3 semen reports down the line, he has 1 million, 2 million, 3 million sperm in the ejaculate, not because of the biopsy, but because semen can fluctuate. There'll be many cases where you'll have azoospermia, then 1 million, then 0.2 million. A semen sample may show azoospermia because of natural fluctuation, because the man has had a recent illness, or because the pathologist has not spun the sample and examined the pellet, which is cryptozoospermia. So these are practically important pointers that need to be borne in mind, that before you label a man as azoospermic, several samples over a period of time when he's not been ill, with the semen sample being centrifuged to look for sperm. And even if a few sperm are seen, that is no longer azoospermia. Equally important, look at all the semen reports. For some strange reason, very often patients come only with the latest report. Doctor said, "Show doctor this report." Always look at the file. If he's had sperm, and now azoospermic, sure enough, afterwards he's going to have sperm. Fructose is important only in azoospermic men. If a man is 10 million, I don't look at fructose. The tragedy is that in azoospermic men, where fructose is most important, often the pathologist does not do fructose, and I'll tell you why. Before that, why is fructose important? Fructose is important because it comes from the seminal vesicle. So if there is a block to the ejaculatory duct, or if the seminal vesicle is absent because the vase is absent, then fructose will be absent. So in an azoospermic man, absence of fructose almost immediately gives you the diagnosis. 9 times out of 10, that is a case of vase aplasia, which you can diagnose even without a clinical examination. 1 times out of 10, it will be ejaculatory duct obstruction. The problem is that the standard fructose test involves 5 ml of resorcinol and 1 ml of semen. When fructose is absent, semen volume is only 0.5 ml. So the lab cannot do the test unless they modify the test. 9 out of 10 labs, unfortunately, write fructose positive without doing the test. And this is not a joke. I have hundreds of men with vase aplasia and absent fructose whose semen report shows 3 ml semen, fructose positive, pH alkaline, because the typist has reflexly typed that without the test being ever done. So very important, you need a dialogue with your pathologist. If you really want to treat a man with azoospermia, they need to spin the sample, they need to look at the pellet, they need to look at multiple samples, and they need to check for fructose honestly. Now, one other very important message, the correlation between FSH and spermatogenesis. Even today, my surgical colleagues, urologists, will send me a patient saying, Rupin, referring so-and-so for obstructive azoospermia. How have they diagnosed obstructive azoospermia? Because he's azoospermic and FSH is normal. Many, many years ago, textbooks used to say normal FSH means normal spermatogenesis. We now know that that is not necessarily true. Many men with testicular failure will continue to have normal FSH and LH. Because if the Sertoli cell function is normal, the feedback loop is normal, you could have a man with maturation arrest with Sertoli only and still have normal FSH. So just because an azoospermic man has normal FSH, that does not mean spermatogenesis is normal. The other way around is true. If the FSH is very high, it does mean testicular failure, but it still does not rule out focal spermatogenesis. So in other words, FSH, we do it, we look at it, but it has only a very limited role in prognosticating what is happening. We'll talk about the genetics of azoospermia as we understand more and more, and we do more and more tests. We find in more and more cases of azoospermia, there is a genetic cause that we need to pick up. So having said all that, the next 10 minutes on the practical approach. Man comes to you with azoospermia, you've asked for 2 or 3 semen samples, he has reached a proper orgasm, the pathologist has done a proper test, and the report shows azoospermia, low volume, that is less than 1 ml, and fructose is absent. The next thing you need to do is either you or your surgeon urologist has to examine the patient carefully, and if the vase is not palpable, the diagnosis without the need for any further testing is CBAVD, congenital bilateral absence of the vas deferens. If he's azoospermic fructose negative and the vas is clearly palpable, the diagnosis is ejaculatory duct obstruction. Now, if you're suspecting vas aplasia, what is the next step? The next step is counseling the patient before you do anything else. If he cannot afford IVF-6C, if he's going in for donor insemination, no further test is required. If he says, yes, doc, I understand I have vas aplasia, I would like to go in for IVF-ICSI, then the next step is genetic testing. Now, what is the genetic testing we need to do? Vas aplasia, in the majority of cases, there is a subpopulation with a different etiology, represents a focal form of a cystic fibrosis transmembrane gene mutation. This is a large gene located on chromosome 7, prone to more than 1,000 different types of mutations. Some of these mutations are mild, some are severe, and knowing the type of mutation is important because if the husband and wife are both carriers of a severe mutation, the child can be born with cystic fibrosis, which is a life-threatening disease. On the other hand, if one parent has a mild mutation and the other doesn't have a mutation, the child is at no risk or may be born with with vas aplasia alone. So in Western recommendations, every patient with vas aplasia, before they go for IVF-ICSI, should have screening for cystic fibrosis. However, this may be not relevant to the Indian population because the white Caucasian population is at a very high risk of cystic fibrosis. In our populations, the risk is very low. So if you look at this data, look at the first circle. In German, Spanish, French, 1/4 of the patients had a delta 508 mutation, which is a major mutation. But if you go down, Egyptian, Turkish, Japanese, Chinese, 0 to 2% had a delta 508 mutation. On the other hand, the poly-T variant, the second column, which is not circled, much, much commoner in Asian, Egyptian, Middle Eastern population, less common in European populations. The 5T mutation is a mild mutation. And therefore, perhaps what we need for our Indian population is very different. Now, we have a grant where we are screening the entire cystic fibrosis gene in the Indian population. This is a study going on at the IRR. Preliminary data shows that our population mutations are very different from the Western population, and that therefore the currently available mutation testing that we have in India may not be relevant. Take home message: if your patient has vasoplasia, ideally they should have cystic fibrosis screening. Second take home message: unfortunately the screening currently available in India is very inadequate. So whether you do it or not, for the time being you are okay. One question often asked: that my patient has vasoplasia, cannot afford IVF, can I just take epididymal sperm and do IUI? You could. Pregnancy rate is only 3 to 5% compared to 40% with IVF ICSI. So certainly IVF ICSI is the better option. We no longer do spermatoseals. The second group of patients, vasoplasia fructose absent, azoospermia fructose absent, but the vas is palpable. These are men with ejaculatory duct obstruction. You cannot manage them, your urologist will, but you need to be aware there are two kinds of ejaculatory duct obstructions. The cystic kind, which you see here, big, fat, swollen seminal vesicle. Your surgeon will be able to do a TUR, the man will become normal. However, you have many patients who have tuberculosis, where there is a fibrous block. If you look at the arrow, you see there's no seminal vesicle, just a thin streak of the vas which ends blindly. Such patients cannot undergo surgery and will need PISA-ICSI. So there are two distinct types of ejaculatory duct obstruction. One group amenable to surgery, the other not. Your surgeon would determine that based on the transrectal ultrasound. Now we come to the second group of patients, much commoner. Azoospermia, fructose is clearly present. In these cases, it may be either an obstruction at the level of the epididymis, or it may be testicular failure, and therefore it is azoospermia. So we need to distinguish between obstructive and non-obstructive. If it is obstructive, we want to know, should he undergo surgery or sperm aspiration? If it is non-obstructive, we want to know, is it correctable, is it reversible? Is he a candidate for sperm aspiration, or does he need donor insemination? How do we determine this? Again, you need a good urologist to examine the patient, look at the testis size, look at the quality of the epididymis, is it turgid or flabby, look at the etiological history, correlate that with the hormone levels and the other findings, and then differentiate the patient into three groups. Either your surgeon will tell you this is clearly obstructive, he has a large testes, a turgid epididymis, a history that would explain the obstruction, and maybe he will directly recommend surgery or do a single needle biopsy. The days of open biopsy are gone. A single needle biopsy using the technique which I showed you in the previous talk, and if that shows normal spermatogenesis, and that is why you need histopathology to establish that it is normal spermatogenesis, then you have two choices. Either the patient could go for reconstructive surgery, bypassing the epididymal block, a vaso-epididymal anastomosis, or we could aspirate sperm from the epididymis, a simple procedure under local anesthesia, and do IVF ICSI. So what should we advise the patient? Advantage of microsurgical vaso-epididymal anastomosis: it costs less than IVF ICSI, allows the couple to achieve a natural pregnancy, protects the wife from extensive hormonal therapy when there is no fault of hers. Ironically, the problem is that microsurgical vaso-epididymal anastomosis requires special expertise which is not available at most places, even though IVF ICSI is available. Advantage of IVF ICSI: much faster than the VA. Surgery takes a long time for a result, may have a slightly higher pregnancy rate, can be done when microsurgery fails or the facilities are not available, but it is more expensive. So from a practical point of view, if the couple is young, below 30, usually we will recommend that they undergo microsurgery, wait for 1 year. If there is no result, then they can still go in for IVF ICSI. If the couple is older than 30, especially over they're 33, 35, time is of essence, or they are under a lot of social pressure, or they don't want to wait, then rather than microsurgery, they could undergo sperm aspiration and IVF ICSI. In those cases where the obstruction is due to tuberculosis or filariasis, IVF ICSI is preferred to microsurgical reconstruction. The second group of patients, and there was a question asked about this, that the patient has testicular failure, small testes, flabby epididymis, maybe elevated FSH. Clinically, you're very sure this is testicular failure. You don't need a biopsy to prove that it is testicular failure. Are any of these cases reversible? If there's been chemotherapy, then you need to wait 3 to 4 years, and in some cases, sperm can reappear after the chemotherapy. What about men with varicoceles? Meta-analysis has also been recently published showing that if a man with azoospermia has a large varicocele, and what is a large varicocele? One that a first MBBS student will diagnose. So not a varicocele that you need to send the patient to Dr. Lulla for. If you can't diagnose a varicocele and he can, that has nothing to do with azoospermia. A large varicocele that stares you in the face and azoospermia, if that varicocele is operated, in 40% of cases, some sperm will reappear in the ejaculate. In most cases, this sperm count remains low. The patient will still need IVF ICSI, but that will be possible with the ejaculated sperm. So if a man has azoospermia, do not send him for an ultrasound to look for a varicocele, because that varicocele is irrelevant to the azoospermia. Only if it is a huge, large, visible varicocele, then surgery may benefit the patient. The vast majority of men with testicular failure, however, will not have a correctable cause. And in that case, the next step again is to counsel the patient. If he cannot afford IVF ICSI, no further testing is needed. They go in for donor insemination or adoption. If the patient of testicular failure, obvious testicular failure, says, "Doc, yes, I want to take a chance with my own sperm," then the next step is genetic testing, and we do two things, karyotyping and YQ microdeletion. If the man has very small testes, tiny testes, 2 ml, 3 ml, very high chance that you will find a variant of Klinefelter syndrome, fairly common in the azoospermic population. 10% of azoospermic men may have Klinefelter syndrome. Interestingly, many of these men will still have sperm in their tiny testes. And what is equally interesting is these sperm tend to be normal despite the fact that the man has Klinefelters. And in one follow-up study of 50 children born from men with Klinefelter syndrome, none of the children had Klinefelter syndrome. However, we still do recommend PGD as a screening because there is some risk of aneuploidy. The second test that we do is we ask for studies, PCR studies, to look for microdeletion in the Y chromosome, AZF factor, azoospermia factor, which is again divided into 3 components, 3 regions, AZF A, B, and C. Now, what is the relevance? If a man has a deletion of AZF A or AZF B, we will not find sperm in the testes. If he has a deletion of AZF-C, in 50% cases we can find sperm, but if we do successful ICSI and he has a male child, the male child will inherit the same defect. So the couple needs to be aware of that. Some of them will say, okay, I'm undergoing this, my child will undergo that. Some of them say if there is an inheritable factor, we do not want to undergo ICSI. So that is the relevance of looking for the AZF factor. So coming back to our flow chart, small testes, high FSH, clinically obvious testicular failure. Wants to undergo ICSI, we do the genetic test. Let us assume the genetic studies were normal. Now we come back to the question. Typically we would say do a trial biopsy, either by the needle or by microdissection TSA. If you find sperm, freeze those sperm, then stimulate the wife, and then do ICSI using the frozen sperm. However, as I already mentioned, sometimes these sperm will not survive freezing. You will have to repeat the procedure, and in 20% cases where you found sperm the first time, you may not find sperm the second time. So if a couple tells me that, "Doc, we want the best possible chance," and it is obvious testicular failure, then we will combine the Weiss stimulation and the TSE and the micro TSE all at the same setting. Otherwise, we will do testicular biopsy first, and we will do multiple biopsies, almost 10 to 15 biopsies. One will go for histopath, the rest go to the IVF center. Finally, you come to the equivocal group where clinically testis size is okay, FSH is normal, you're not sure, is it obstructive, non-obstructive, does he have sperm, does he not have sperm? We no longer do a single biopsy. We will usually do 6 + 6 biopsies from both sides. One biopsy will go for histopath, the remaining will go to the IVF lab. If the IVF lab finds sperm, they will freeze the sperm. If the IVF lab finds many sperm and the histopathology is normal, that is a case of obstructive azoospermia, and the options are either reconstructive surgery or IVF ICSI. If in all the 12 biopsies we find no sperm at all, neither in the IVF lab nor in the histopath, this is a case of testicular failure. Most probably we will not find sperm. The patient needs to undergo donor insemination. If the IVF lab finds a few sperm and histopath shows maturation arrest or testicular failure, this is a case of testicular failure with focal spermatogenesis. This couple can still undergo IVF ICSI. So we no longer do single biopsies in equivocal cases, either a 4-quadrant biopsy or a 6-hextant biopsy on both sides, with the samples going both to the IVF lab and the histopathology for double evaluation. So to summary, the management of azoospermia is far more interesting, far more challenging than oligoastheno, and we need to look at all the issues that we've discussed: good semen analysis, proper interpretation, proper technique of biopsy, proper evaluation of biopsy. You have the option of micro-reconstructive surgery, you have the option of IVF ICSI, and then a large number of these men who previously had no hope will be able to father their own child. Thank you.